Okay, so yeah, so we don't necessarily need to walk through that whole thing, but I would love to clarify anything you ran into you weren't sure about when you were walking through that, or
Yeah, we're gonna put the second column with the column and 5 columns. What's going on right there?
the second one, yeah, so for you guys on Zoom, Josh's question was so I guess the third one, the one that's titled endothelial cell activation, right, that one? Or no?
Like in between the L, like the stage, the free radical LDLs and the T cells and the macrophage stuff in between.
You're talking about this one?
Yes, sir.
Yeah, okay.
Sorry, I didn't see that.
Yeah, no, it's okay. Yeah. So in that stage, he's asking what's going on in that stage. So in that stage, we're starting to see some collagen. So what that would mean would be that there must have been some growth factor release already at that point, because that's really what is going to be stimulating that collagen release. And that could be just from the cells, the endothelial cells here, if we technically don't really have any immune cells in there yet. And so there's just like the initial phases of like the scarring starting to happen. That's what the collagen would be. And then the VCAM and ICAM, that's really the end of, with the decrease in nitric oxide, then we start seeing that VCAM and ICAM and selectins. And then that's really what's going to, take us to the next stage, which would be calling in the monocytes and T cells as well. But it is a little bit out of order compared to the way I had it in the slides, with the collagen kind of showing up before the immune cells show up. But it's probably just the actual endothelial cells starting to produce a little bit of scarring there, which, is that kind of what you're getting at? Or okay, what else? I think Michaela, or did you have any hand raised too?
I was just asking, is this like similar to like a pulmonary embolism, which is like it's release?
So it definitely could. This could result in a pulmonary embolism. So this thrombus could end up anywhere really. Typically like a pulmonary embolism might have a separate cause outside of atherosclerosis, and that could happen more from heart failure with the blood pooling that occurs with heart failure. This thrombus could end up going anywhere and getting stuck. So it could be the heart, could be the brain, could be the lungs.
Thank you.
So for sure. So it's a thrombus when we just went through this in the Bio 1040 class. It's a thrombus when it's a blood clot that's just like this, like stuck somewhere. It's an embolus when it starts rolling through the bloodstream, and then it becomes an embolism when it gets stuck somewhere again. I guess is the kind of three different. Is that right, Zita? You remember? Yeah. Zita's in that class too. So I don't have my slides in front of me, but yeah. So okay. What other questions on this? Anything else to clarify here? How about you guys on Zoom? Anything else that needs clarification here? Okay. All right. Good. Okay. So so let's keep walking through here, and now we'll kind of move into the effects of exercise now. Okay. So since the first step in the progression of atherosclerosis is that impaired endothelial function, first really question how does exercise impact endothelial function? Okay, and so the big deal is this idea of shear stress. Okay, and so shear stress means, so normally blood is just kind of flowing through the arteries, kind of just mostly going straight through. But then when we start exercising, or we have an increase in blood pressure for some reason, blood doesn't just go straight through, but it starts kind of churning around in there, right? And it starts kind of pushing out on the walls of the artery a little bit. And that's known as shear stress. Okay, so however much kind of pressure you have pushing out on the walls of the artery from the blood, that is shear stress. Okay, and that's a stimulus to those endothelial cells to number one, to activate to the enos. Okay, so that shear stress activates enos. Enos starts producing nitric oxide. Okay, so there's multiple things that shear stress does, but it would first of all just activate enos. Okay, and by doing that, that just makes it create nitric oxide. Okay, so then we have an increase in nitric oxide, and that's directly caused by that activation of enos. And that also increases the amount of enos too. So that doesn't happen immediately because that's going through protein synthesis and creating more protein, but that takes a while. But but that activation or that shear stress actually stimulates the cell to start making some more ENOS, okay? And making healthy ENOS too, because that was part of the problem too, is that ENOS wasn't really doing its job properly. And so really that shear stress is in all ways going to lead to more nitric oxide availability, right? And that's really what that's saying there. This overall increase in nitric oxide availability. Okay, and then if we go back to the beginning of the progression of atherosclerosis, if we just did that helps a lot, right? Because we didn't, because if we have more nitric oxide, then we inhibit the cellular adhesion molecules. If we inhibit those cellular adhesion molecules, we don't get the monocytes turning macrophages and coming in. We don't get the T cells coming in. We don't get that whole progression of inflammatory response, right? We might still have some LDL there. But if we don't have the macrophages there to engulf it, then we don't have an issue, right? So really cutting this off from the beginning is the best thing to do. So that's one of the reasons exercise is so powerful of a stimulus for improving vascular health. Okay. So those are kind of the three things that directly do that. And then these are also going to lead to a decrease in blood pressure too, right? Because the more nitric oxide we have, the more we can vasodilate, and the more we can vasodilate, the more we can decrease our blood pressure too. Okay. And then I guess I'll add one other one. If we have, well, I'll also do the arrow right here. If we have more healthy ENOS, then we're going to have decreased oxidative stress. Right? If we have decreased oxidative stress, then we're going to have a decrease in that oxidized LDL. All right, so then this is kind of turned into a concept map already, but if we have decreased oxidized LDL, then we're going to have decreased macrophage engulfing of LDL, right? And we'll go through that again we'll go through kind of a chunk of the concept map together on Friday, but that's kind of the beginning of one there. Okay, and so there's been a ton of research around what type of exercise would be best for improving endothelial function, right? And one of the places that hit so high intensity interval training looks like it could be helpful, maybe more helpful than continuous, is potentially for improving endothelial function, improving vascular health. So that was actually what I did my dissertation on. So we'll dive into that a little bit here in a second. So we'll answer some of those questions as we keep going. So this was my dissertation study that we did a while ago now. I graduated with my PhD in 2013. So yeah, it's been 8 years, I guess. That's a long time ago. Yeah, so pretty much we had obese sedentary adults. They were otherwise healthy, except for having a BMI of over 30. And they didn't exercise much. Okay, so we had 18 that actually finished the study. They three sessions a week of exercise for 8 weeks. Okay, there was half of them were in the HIIT group, half of them were in the continuous group. Okay, so the HIIT group looked like 10 1-minute intervals of getting their heart rate up to 90 to 95% of max for a minute. Okay, and then so they go up for a minute, and then they kind of cruise for a minute, go back up for a minute, kind of cruise for a minute. So 10 rounds of that for each session. And then the continuous was just 30 minutes at 70 to 75% of max heart rate. So much shorter, 29 minutes per session versus 40 minutes per session. Okay. Yeah, and so really so over the total 8 weeks, you can see, 4.5 hours shorter of exercise in the HIIT group. And that's always one of the benefits of HIIT, is that maybe the effects are similar, but a lot of times it's 25 to 30% less exercise time than a continuous session. And so you can get the same effects with less time, and people usually like that, especially because that number one cause or number one stated reason people say why they don't exercise is because they don't have enough time, right? So, okay. So yeah, so the primary outcome in that study was this measurement called flow mediated dilation, or FMD, right? So we measured all kinds of stuff in that study, and we're still analyzing some of the data, but the primary outcome was FMD. Okay, so what you do with FMD is you have an ultrasound machine, and you take that ultrasound machine and you look at their brachial artery right up here. Okay, and so that's what's going on right there. So ultrasound machine looking at that brachial artery, and what you do is you get a measurement of that brachial artery while they're just laying there, while there's no stress on the body. Okay, so that would be considered the baseline measurement or resting diameter. Okay, and then what you do is you take a blood pressure cuff and put it on the forearm, and then pump it up to 250 millimeters of mercury. So you're cutting off blood flow beyond the cuff. Okay, and then you do that for 5 minutes. So you occlude the blood flow for 5 minutes, and then you release that cuff. And what happens is you get a hyperemic response, meaning that the body's trying to make up for not having blood. So it sends a bunch of blood down the brachial artery, right? So you get this big rush of blood. And because of that, that's causing shear stress, right? So the blood is pumping through and it's coming through so much that it causes a bunch of shear stress. So you get a bunch of pressure on the walls of the artery, the brachial artery, and all the arteries. And that stimulates nitric oxide release, right? That stimulates eNOS activation, nitric oxide release, and it causes vasodilation. And so what you're trying to see is what's that peak diameter, right? So then you have resting diameter, compare that to peak diameter, and you get a percentage change of how much dilation you can get. That's what flow mediated dilation is, right? So that's really what we're looking at, is that percentage increase in diameter. Okay, so this would be kind of a schematic of what's going on physiologically during that test, right? So this would be inside of a blood vessel where the blood's flowing through. Well, we go both ways. And so we get that flow of blood creating a shear stress stimulus. And so there's actually little proteins on the walls of those endothelial cells that are little mechanoreceptors, and they sense pressure, right? So they sense that shear stress. And when that shear stress hits them, this whole chain of events occurs, but in the end, it activates eNOS, right? eNOS makes nitric oxide, and nitric oxide diffuses not into the blood, but actually into the wall of the artery, right down to where the smooth muscle is. Okay, so that nitric oxide goes down into the smooth muscle cells and then leads to relaxation of that smooth muscle and vasodilation. Okay, so this is what the ultrasound images look like. So when you got that cuff on their brachial artery, you get something like this. Okay, and this here is the brachial artery. Okay, right down here will be the brachial vein. When you get a cool image, sometimes you can see the valves of the brachial vein down here somewhere, but that brachial artery is there. And so then you use this advanced software that detects the edges of these walls and then measures the distance between the edges, and you get the average of it. And then it's also picking up blood flow. There's a Doppler as a part of this, so that you put the Doppler probe, that's what this guy is right here. So the Doppler probe is picking up blood flow, so it senses how much blood's passing through. And then it gives you these numbers. So over here would be diameter of the artery. Over here would be flow, and then sorry, this one's flow, the yellow one's flow, and the red one's velocity of the blood. Okay, and so these are videos, but they don't play when I'm doing it on my iPad. But pretty much, if I was able to play it, what you would see would be it's getting resting diameter, just like this, resting blood flow, and then right shortly after I would hit play, the cuff, I would release the cuff. And you would see this huge increase in flow. So the flow would shoot way up here. You would see these big spikes in the blood flow velocity. And then also down here in the blood flow, you would see these big spikes. That's when the shear stress occurs. And then it takes about 60 to 90 seconds where the diameter wouldn't really change. But then after about 60 to 90 seconds, then you would see diameter start slowly creeping up. And then this is kind of our final look at what the ultrasound software gives us. So here's our resting diameter over here. This is where you can see it starting to dilate, right? And then it peaks out right there pretty much. And then it starts going back down. And this is where you see that big flow increase when the blood pressure cuff was released. Okay, so this was our baseline diameter over here. This was our peak. And so that's a 4% FMD there. And this was one of the obese subjects before training. And so really the number that we kind of the reference number for FMD is at 7%. So anybody under 7% is considered at a higher risk of having a cardiac event. And it's so predictive that for every percentage below 7, it increases the risk of having a heart attack and stroke by 13%. So this person right here was at about a 40% greater risk of having a heart attack or stroke by having a 4% FMD instead of a 7. So it's a really predictive test, and it's non-invasive, and that's why it's a good measurement. It's used a lot in this research. So yeah, so that's the FMD. And so we did this test at baseline. We did it at 4 weeks, and we did it at 8 weeks. Okay, and so this is what we saw. So in the baseline test here, you can see was about a 4.5% FMD on average in both groups. Okay, HIT and continuous were pretty close to each other there. And then we see the HIT group just kind of slowly go up. And that went up to about 8.2% in just the 8 weeks of exercise. Whereas a continuous group, it almost looks like it goes down. This decrease wasn't a significant decrease, so it kind of just stayed the same. So in this study, definitely HIT was better for improving FMD than continuous was. And this was kind of one of the first studies that was actually done in obese adults in this way. But the interesting part was, it wasn't like continuous didn't help them at all. What we noticed in the continuous group was this one right here. So this is resting artery diameter here. So resting artery diameter had a significant increase in the continuous group and not in the HIT group. So what that means is that their arteries actually, or it could mean is their arteries actually adapted in such a way that their arteries just got bigger. And so that's called a structural adaptation versus the other one where they just get better at dilating. That would be more of a functional adaptation. So both adaptations were good. So it was just kind of an interesting finding in the study that we saw continuous lead to the structural adaptation and HIT leading to the functional adaptation. So yeah. Any questions on that? Okay. All right. Some other research has been done in this area with HIT in particular. HIT has been done in people who have heart failure, and one of the first studies that came out where they looked at this was back in 2007. It was in a Norwegian group, and they pretty much took 27 patients who had a heart attack, so post-infarction heart failure patients that had a heart attack, which led to them having heart failure. And they did 12 weeks of 3 days a week of HIT. Okay, and they didn't do the 10 by 1 like we did. They did 4 by 4, which is way harder. Well, it depends. Some people like the 4 by 4 better, but it's pretty much 4 minutes on with a 3-minute rest interval. 4 minutes on, you do that 4 times. And so, yeah, just imagine people with heart failure who just had a heart attack doing that. But it's all relative to their max heart rate, right? So an on time for someone in heart failure might look like going from walking at half a mile an hour during the recovery period to walking at maybe 1.5 to 2 miles an hour with maybe a 1% grade or something like that would get them up to 90% of the max, right? Because the VO2 max, people with heart failure, VO2 max might be somewhere around 15 to 20 mLs per kg, right? So yeah, so it's not like they're sprinting on a treadmill or something, right? They're walking, but that still is getting them up close to their max. When the study first came out, it was just kind of shocked everybody because it's like, wait, people with heart failure are doing high intensity interval training. This is crazy, right? And even still today in the US, it's very uncommon in cardiac rehab centers to see anything above a moderate intensity, even though there's lots of research mounting to show that high intensity leads to the heart adapting much more rapidly than the continuous exercise does. But they saw some pretty drastic effects. So they doubled their FMD. Their VO2 max went up by almost 50%, which is an incredible increase in VO2 max. We don't expect to see that even with a year of training. We typically might expect to see 20 to 30%, but to go up almost 50% in just 12 weeks was pretty incredible. Their ejection fraction in the heart went up by 35%. So that's that contractility. This is just a marker of heart failure, went down by 40%. So pretty drastic improvements with that. And that was all in HIT group. When I was at ASU, this guy here, Sid Angadi, was the guy I got to write that paper with. You guys looked at last time. His dissertation was on heart failure patients, and they just did 4 weeks of HIT versus standard cardiac rehab, and were able to see on a 3-point grading scale of heart failure, on average, the HIT group went down a full point on that grading scale of heart failure in just 4 weeks, and they only did 3 days a week, so that's like there was only 12 exercise sessions. Some of them went from having grade 1 heart failure to not having heart failure, just with 12 exercise sessions. So pretty drastic effects of that high intensity interval work on people that have heart failure. So yeah. Okay, any questions on those? Anybody on Zoom? Nothing? Okay. All right, so that's a little bit about endothelial function as well as the effects on the heart. But what about blood pressure? Okay, so blood pressure is one of those big risk factors we talked about for sure. So hypertension. So the cool thing about blood pressure is we have both a chronic effect and an acute effect. And so an acute bout of exercise can decrease your blood pressure for somewhere around 13 millimeters of mercury for about 8 hours. Okay, so that's just doing one bout of exercise. Okay, so people, when people started seeing this research come out, they started thinking, well, like, okay, then maybe for people that have high blood pressure, maybe instead of just them doing a 30-minute bout in the morning, maybe we have them do a 10-minute bout in the morning, 10-minute bout at lunch, and a 10-minute bout in the evening. And then they get this post-exercise hypotensive effect for the whole day, right? And so there's been quite a bit of research done about that. There's this, it's kind of turned into this idea called exercise snacking. You take little snacks of exercise instead of a big meal of it. And for things like blood pressure, it tends to be better because you get that post-exercise hypotensive effect for the whole day. So that's pretty cool. And then even the people that say like, well, I just don't have time to exercise 5 days a week. I just can't do it. Well, just do it once. I mean, then you got at least one day where your blood pressure is a little bit lower, and that helps your arteries for sure. But then chronically, if we want to look at like resting blood pressure before somebody starts a training program, and then after, we might expect to see some changes, something like that. Systolic dropping 7 millimeters of mercury, diastolic maybe 6, somewhere in there on average. And then it's always a question of, what's the best type of exercise? With blood pressure, it tends to be actually moderate intensity exercise that's better for this than high intensity. That's just what it seems to look like is moderate intensity, longer volume is probably a key factor. Like longer time exercising, not so much about how intensely that somebody's exercising. Okay, so that's our blood pressure effect. Dyslipidemia, so that would be.
I have a quick question about hypertension.
Go ahead, Dan.
So for chronic exercise, is there a certain time period for that, like there was with acute bout exercise?
Yeah, good question. So that would be, that's kind of an accumulation of a bunch of different studies, intervention studies that have been done. But typically they're anywhere from 8 weeks to like a 6-month intervention. But I think you could expect to see something like that in somebody who has hypertension in at least a 12-week intervention. You would expect to see something like that. Does that answer your question?
Yeah, and then another quick question. So how long would something like that last? Like if you stopped exercise, like would it still stay steady and then just drop off?
Yeah, so if you did like a 12-week exercise program, dropped your blood pressure, and then just stopped exercising after that, yeah, you'd probably benefit from those effects for a little while, probably with a few weeks or so until it started kind of going back up again. But yeah, after a couple months of not exercising, it would most likely probably go back to where it was before. But weight is a big factor when it comes to blood pressure, and so that could be another factor too. If they were able to lose some weight with whatever program they're doing, and they were able to keep that off even without the exercise, then they might maintain some of those blood pressure benefits a little bit longer, even if they weren't exercising. Cool, thanks. Good question. Other questions on that? Yeah, anybody else on Zoom? Feel free to unmute like Dana did. That's totally fine. Okay. All right. So what about cholesterol levels? And so physical inactivity has been shown to decrease our HDL levels by somewhere around 4.5%. Okay. So HDL is the one we want to be higher, right? So just when people don't exercise, HDL goes down. Okay. But if we take people that aren't exercising and put them on an exercise program, we can expect to see our total cholesterol and LDL levels to decrease by somewhere around 10 to 15%. Okay, so again, that's not huge, but it's definitely something. It's helpful. And then we can expect to see HDL to increase by kind of a larger range, somewhere between 10 and 17%. And then triglycerides are another important risk factor for cardiovascular disease. And we can expect to see those decrease by somewhere from 10 to 20%. And obviously, as the cartoon suggests on the side, diet's a big factor for cholesterol levels, right? It's not just about exercise, right? Diet's a huge factor. So yeah, and, as well as for all of these risk factors, diet is a huge factor. Okay. All right, and then what about exercise on inflammation? In the article you guys read talked about this some. So aerobic exercise leads to decreases in most of the pro-inflammatory cytokines. So this is just kind of a list of ones that have been proven to decrease, and then increase in the anti-inflammatory ones. And those are three of the most prominent ones there. Okay, so all of these are just mediators of the immune system, either activating those immune cells to cause more inflammation or decreasing their function so they don't cause so much inflammation. And so when you map this out on the concept map, if you chose this one, then I would recommend at least putting the names of those in there at one point. There'll be multiple places where you say things might lead to a decrease in inflammation. So maybe just at one point, put the names of the cytokines in there, like an increase in these ones and a decrease in these ones. So I think you can just use this information right here for that. Okay, so we get this anti-inflammatory effect of exercise. And then the last kind of stages of the atherosclerosis is blood clotting, and then that plaque actually breaking, right? And so aerobic exercise has been shown to decrease the things that lead to plaque rupture. And those are the ones we were talking about, those NMPs. Also the angiogenic factors, the things that cause the plaque to start getting its own blood supply, right? So that would be integrin. And then another one that isn't on that progression slide, but it's another one that leads to vascularization of the plaque is angiotensin II. We've talked about that one a lot, obviously, in other ways about blood pressure. Okay, so exercise decreases all of those things, so it decreases or it actually increases the plaque stability, makes it so that plaque's not as likely to rupture. Okay, and then it also decreases the factors that lead to clot formation. So fibrinogen, we already talked about that one. So fibrinogen is the thing that turns into fibrin to form the clot, right? It's that plasma protein that's always there. And then PAI1 is kind of a confusing one because it's like a double or maybe even triple negative, but it's plasminogen activator inhibitor. Okay, and so it inhibits the activation of plasminogen, but exercise decreases that. So they're decreasing the inhibition of activation of plasma. Yeah, so just trust me when I say that decreasing, that's a good thing. So plasminogen is the plasma protein that turns into plasma in the very end of the clotting process when we want to clean the clot up, right? When we want to actually break that clot up and get it out of the way because the vessel's been healed. So the more plasminogen we have, we actually can clean up the clot and get rid of it. Okay, questions on any of those? All right, so let's take a second now, and you guys that have the paper one in front of you can flip that over, and you guys on Zoom, I'll just put this back up, or you can just pull it up on your computers. But I'd like you to kind of plug in where exercise hits all of these different factors in the progression of atherosclerosis. Okay, so you guys on Zoom, all right, so with type 2 diabetes, there are really three primary factors that are leading to high blood sugar, hypoglycemia, right? And so it's not just about this one, which is kind of what we typically think of when we think of type 2 diabetes, is we think that the insulin, something's going on with the way that insulin is working. It's not working, right? Insulin is binding to the cells, and there's some mess up in the pathway there, so we don't get as much food forward on the surface. That's kind of the basic understanding of type 2 diabetes. That would just be the decreased glucose uptake side. That is definitely one of the primary factors. And so we see decreased insulin signaling, right? So a certain amount of insulin binds to a muscle cell, and that should cause a certain amount of GLUT4 to come to the surface, so glucose can then come in. GLUT4 is that protein that serves as like the channel for glucose to come in, right? But in somebody who's insulin resistance, or who has a decreased insulin sensitivity, or has this decreased insulin signaling, it's kind of all the same thing, just different words. You wouldn't get as much GLUT4 that came to the surface, so you would need more insulin to get the same kind of glucose uptake response. Okay, and that's what insulin resistance is. That's highly related to a decrease in mitochondrial function of skeletal muscle. And it's also highly related to lipid accumulation in muscle, and in any cell really, but muscle is where 85% of our glucose is stored. So that's why this is really such a disease that's so tightly linked with skeletal muscle. Okay, so that's one factor. But the other factor is the pancreas. Okay, so those beta cells, the beta cells are what make the insulin for us, right? And so we have impaired insulin secretion in the beta cells in people who have type 2 diabetes. Okay, now type 1 diabetes is that your beta cells are shot, right? Your immune system has destroyed your beta cells. Okay, and you don't have any insulin release. Type 2 diabetes isn't that way, but it can be that way in the end stages of type 2 diabetes. Those people need to start taking insulin injections just like type 1 diabetics because their pancreas is completely shot. So that's factor number 2. And then factor number 3 is this one, increased HGP, which stands for hepatic glucose production. Okay, so it's your liver releasing glucose into the blood. Okay, so your liver is primarily responsible for maintaining your glucose levels when you're not eating. Okay, so when you fasted, you don't have any glucose coming in, then the liver is pretty much sensing how much glucose is in the blood and releasing just the right amount to maintain your blood glucose levels. Okay, but the problem is when you're, so then on the other side of that, when you eat a meal and your insulin levels spike, that insulin should go to your liver and tell it, all right, we don't need any more glucose because we got it coming in from the meal. And so then the liver stops releasing glucose, okay? But in type 2 diabetes, that doesn't happen. We get insulin resistance in the liver as well. So that insulin goes and binds to the liver and tells it to stop releasing glucose, but it doesn't stop. And in some cases, it actually releases more. Okay, so that's a decrease in insulin sensitivity in the liver. This is all tightly linked with visceral fat and what's known as portal vein theory. And I'll explain that in 1 second. Okay, so those 3 factors are kind of the 3 primary factors in hyperglycemia in type 2 diabetes. So it's the skeletal muscle not taking up glucose enough, it's the liver releasing too much glucose, and it's the pancreas not being able to release as much insulin as it needs to. So if you're doing the concept map for this one, then you need to address all 3 of those factors in the concept map. Okay, so let's talk about visceral fat a little bit. So visceral adipose tissue, this is kind of a schematic that shows kind of how we form visceral fat. Okay, so it's always about this balance of energy, right? So if we have an increase in energy intake, meaning we're eating more, and we have a decrease in energy expenditure, which means we're not moving as much, right? Then that results in a positive energy balance, right? We've got more coming in than we do going out. And your body is so incredibly efficient at maintaining, holding on to energy, right? Because our genes are the same genes that, it's the same genetic makeup that hunter-gatherer societies had. And so pretty much those genes were programmed to hold on to every single calorie that came into the body, right? Because they went through periods of feast and famine all the time, right? So they would get a big kill a buffalo or something and just feast like crazy on that thing, right? And then it might be another 2 to 3 weeks until they get another large meal like that. So it makes perfect sense that you would want to hold on to every single one of those calories that we're eating, right? But the problem is we always have the buffalo in front of us right now. It's always on our plate, right? We can always have access to that. And so we're always in this positive energy balance state, typically in Western society. But the genes are programmed to hold on to every calorie, right? And so when we're in a positive energy balance state, it's not like your body just gets rid of that excess energy, it holds on to it, right? And it turns it into fat, right? And so at some point, when your subcutaneous adipose tissue, which is the stuff under our skin, once that gets full, what happens is the body still says, okay, that fat's full, but I'm still gonna hold on to these calories. So then it sends it to visceral adipose tissue instead. So it's this idea of lipid overflow, okay, when we can't, inability of subcutaneous adipose tissue to expand. Right? If we can't increase our subcutaneous adipose tissue anymore, then we got to send those excess calories somewhere else. And so that looks like this. So we get this increase in fat in all around our organs. Also in our organs, the liver starts filling up with fat, the heart starts filling up with fat, muscle, kidneys, pancreas. And then in those organs, we get something called lipotoxicity, which is bad makeups of fat actually start damaging the cells of that tissue. Okay. And that leads to inflammation, insulin resistance in the pancreas. That's partially what causes the impaired release of insulin in the pancreas. So this is definitely caused, so that inflammation that we see in our arteries is just kind of egged on from inflammation everywhere else too, right? If we've got a lot of inflammation all through our body, we've got high levels of pro-inflammatory cytokines. Those are going to interact with our vascular system too, the macrophages and T cells that are there. And it's going to cause them to be more active and cause more inflammation in the arteries, right? And so that leads to cardiovascular disease and then also the risk of type 2 diabetes. Okay, so heavily linked to both of these diseases is that visceral adipose tissue. So questions on that at all? Okay. All right, and one of the reasons why, at least for when it comes to the liver, is this thing called the portal vein theory. So we have this big portal vein inside of us that is taking the blood from the digestive tract and dumping it into the liver. Right? If you remember, there was the portal system is the blood is picked up or blood gets filled up with nutrients that are being pulled out of the digestive tract that you ate. And then it goes from there, from those capillaries into some more veins. But before it goes back to the heart, it goes to the liver first. And that's what the portal system is in the liver. And it's dumping all those nutrients into the liver because the liver is responsible for processing a lot of our nutrients. And so one of our biggest visceral fat depots is sitting right next to our portal vein, pretty much. And that's one of the most likely places for us to build up visceral fat. And visceral fat's very active and it's constantly releasing free fatty acids into the blood. And so if we have all this visceral fat right next to that big portal vein, then the next stop for it is the liver, right? And so we get what's called non-alcoholic fatty liver disease, which is pretty much fatty liver disease can happen from drinking a lot, but it can also happen from having high levels of visceral fat. And this is kind of a theory as to why. And so that would be directly linked to that hepatic glucose production, having fat build up in the liver. Okay. Yeah, so this is kind of why I mentioned before that waist circumference is almost like a vital sign, because we're looking at that gives you some idea of visceral fat. Okay, and I'll end with this one here, but this one is just a kind of a direct link between type 2 diabetes and cardiovascular disease. So this would be healthy over here. So we see an insulin receptor, there's insulin. When insulin binds that insulin receptor, all kinds of different things happen here. One of the things is GLUT4 going to the surface of the cell, so we can let glucose in. But look what else happens. That's a direct stimulator of eNOS. Right? So insulin is actually vasodilator. Right? It actually stimulates eNOS, which stimulates nitric oxide production, which causes vasodilation, which also just causes a healthy vascular system, right? So, but then what happens when we have insulin resistance is we get all kinds of potential things that are getting in the way of each one of these pathways. Some of these are fats, ceramide's a fat, DAG is a fat. And so what happens instead is we don't get as much GLUT4, so we don't get all that glucose uptake, but we also get a decrease in eNOS instead, which would lead to a decrease in nitric oxide, which is directly tied to endothelial dysfunction. So there's this one direct connection between these two diseases, which are so tightly linked to each other. Don't worry about all the little factors in there. This is more just showing that overall connection between type 2 diabetes and cardiovascular disease. Okay, so we'll stop there. We'll get into the effects of exercise on this next time. And then, like I said, we'll take a little bit of time probably to walk through the an example concept map for that as well. Okay. All right, guys. Have a great rest of your day. We'll see you on Friday on Zoom.